Hello, and welcome to the latest episode in our series of the ASTRO President's Member Spotlight. I am joined today by the man, the legend, Dr. Vedang Murthy. He is a professor, radiation oncologist at Tata Memorial Hospital in Mumbai, which is an incredibly well-known center across the world. And his area of clinical expertise is urologic cancers. But I would say Dr. Murthy carries expertise in many areas well beyond that, including, of course, the delivery of high precision radiation therapy, the development and clinical protocol advancement of image guided radiation therapy, as well as adaptive radiation therapy. And so, of the many hats he wears, one of them is a mentor to many, and certainly I consider myself one of the fortunate who've been able to learn from and work with Dr. Murthy. So thank you for being with us today.
Thank you so much, Neha, if I may say so. More like a friend, a colleague, and of course, ASTRO President. Absolute honor to be here and have a chat with you today. Thank you so much for the invitation.
Of course, I think there are many of our ASTRO members as well as radiation oncologists worldwide who know of you. But I wonder if you could share with us today, what is it that when you, go to work and you are there in your clinic and with your colleagues and your mentees, inspire you in particular in the clinical trial space where you have had tremendous success in truly practice changing and practice informing research. And so I just think for those that are listening, thinking, how would I even begin? How do I get started? Could we learn some words of wisdom from you?
So what keeps me going actually is the patients. You would agree more than anyone else, seeing them, comforting them, treating them, speaking to them, giving them some time in spite of time being the biggest resource constraint that we have, more than anything else. So speaking to them and seeing a smile on their face and often a tear in their eyes is, I think, what keeps me going. And I tell my residents, you're going to learn 70 gray or 80 gray or this fractionation or that fractionation, but doing the right thing in the clinic with the patient, I think is the most paramount before anything else that we do. So I think that keeps me driving. Now, as far as research is concerned, and I'm going to speak about this later this month in the APCCC, while we may be resource constraints, I think what we have are the most important and the best questions that need to be answered. The most relevant ones are with us, and we have the numbers to back them up. Now, I think what I realized several years back, is that we must make a start to answer the questions that nobody else will. And we can. So that is how the ecosystem started. That is how we built the ecosystem, creating a database of what we have. And one step at a time, like running a marathon.
Yeah. No, absolutely. I think the infrastructure that you have built, it just goes to show that wherever in the world you may practice, again, if it's patient-centered, if the clinical questions you're asking are truly relevant to day-to-day practice, then the rest will follow, right? Not only patient enrollment, but support for that study and then the applicability of it. So, what do you say to individuals who might say, okay, well, the patient population in India has certain characteristics, and so these findings, they may or may not be immediately relevant to my practice in Oklahoma in the United States, for example. And what ways do you try to address that potential concern or limitation?
Absolutely right. Particularly with this whole pelvic radiotherapy business recently, whether it's relevant in the United States or not, is become an issue of hot debate right now. What I think is, outside the United States and Western Europe, there's a whole lot of people who see exactly what we see. And I think they take a lot of inspiration from the work that we do, because they can see that these are exactly the patients that they are seeing. Having said that, I think a lot of the things are also relevant in the United States. It is not that most of the things are not. So it really depends on, how you look at the evidence.
I couldn't agree more. And, I think there's so often this sense of, oh, okay, well, certain countries may have better access to certain technologies, and there might be some assumptions made there. But the reality is, you conducted one of the first clinical trials in which the majority of patients with prostate cancer were imaged with state-of-the-art PET. And actually, there are many places in the United States that are quite behind in that regard.
Mm.
Obviously, things have caught up now, much more so, but Australia, India, certainly many other parts of the country where this was quite the norm for long before we had it in the US. So I think there are actually many ways in which the global stage of clinical research has helped all of us to learn more about different technologies, to learn more about staging and stage migration, and the implementation of different technologies, right? We love our toys and our tools in radiation oncology, but how to actually effectively utilize them and derive patient benefit, that's not always a given, right? Just because we have the fancy tools doesn't always mean they benefit. So I think the contributions that Tata Memorial, that your work, and many others have done across the country and across the world, I think have been incredibly informative. So, and I love to point out, Astro's focus increasingly has been to, bolster these partnerships with various centers and countries around the world, and sort of this global oncology emphasis more than ever, because we really are, I think, united by so many of the same quandaries, right?
Yes.
The same things that your trainee asks you, why do you do it this way? And what's the evidence supporting that? That's universal, right? Um,
Absolutely, absolutely. One thing I may add, the advantage that I have, or a smaller team like mine would have over, say, a large cooperative group. Obviously, there are several disadvantages, but the biggest advantage is we can be very nimble in what we do. We can change course as things are happening. We can think ahead without having a zillion meetings just to figure out when to meet next. So
yeah.
being nimble, I think, has been a very important factor in what we do. We can change course, put a quick amendment in the IRB, get it approved. Few people decide most of the things, a smaller team. So I think it's a big advantage if you get the question right.
If you get the question right, and of course, maintain whatever the statistical design and everything else, the integrity there, absolutely right. And I think those of us that have participated in sort of these big cooperative group efforts can absolutely not only empathize with the points you made, but shed some tears over just how nimble that mechanism that you just described is compared to the very heavily bureaucratic process. And, to the extent that that bureaucracy is slowing things down
Mm.
and, delaying answers to really critical questions, it is a shame. And I think that, smarter methods, more
Mm.
pragmatic approaches to clinical trials is exactly what your team, I think, has done a beautiful job showcasing. So
Thank you.
thank you for all those efforts. Um, what are you most excited about as a radiation oncologist when you look at the next 5, 10 years, moving ahead, whether it's in the clinical research space or really any area of practice?
It's got to be automation. I think we are doing a lot of stuff that probably doesn't need to be done. And you know, my residents still contour. I don't know if yours still do that, but I
They
think.
do. They do.
So
Good folks.
I mean, all the contouring, planning, replanning, it's got to be automated. I mean, we are already on the verge of moving. We can really focus on the real stuff. I think we've been doing a lot of things that the machines, the intelligent machines can take over, and we can spend more time with the patients, more time thinking about trial designs and answering questions that are relevant to our patient. I think that is what that's going to happen, and very excited about that.
Yeah. And to the junior trainee, which I certainly have, or the junior faculty who says to you, but Dr. Murthy, does this mean we're going to automate ourselves out of a job? What do you say to those concerns?
We're going to automate ourselves out of a boring step, a repetitive step, and do the more important things like talking to patients, looking them in their eye and comforting them and taking care of their symptoms, taking care of their pain, and taking care of their cancers. I think that's what we should be focusing on.
Absolutely. I think operating or allowing all individuals to operate at the top of their scope
Yes.
and to continue to evolve their training, right? And certainly in medicine, it's always been true, I think, that you don't stop learning after you get that degree or you
No.
complete that residency. It's really only just the beginning, right? Continuous learning. And now we're having to learn different skills and also, as you said, hopefully spend more time on the humanistic skills, the side of it that makes
Absolutely.
doctoring what it is. And I'd like to believe, at least for current state of things and all the people in the world today who need care, I'd like to believe that as much as they may appreciate automation of some things in their medical care, at the end of the day, they want a human
Yes.
on the other side who's holding their hand, who's explaining
Yeah.
what's happening, and who's helping to answer those questions through that interpersonal connection. So
Yeah.
I'd like to believe there's no replacement for that anytime in our
Yeah.
future.
Uh,
And I do
you
believe
know,
that.
our field is at a risk of getting too much away from the patient, being so technology driven, unlike
Yes.
medical oncology, who have a ward full of patients, or surgeons who have a ward full of patients, post operative care. A lot of us and a lot of our colleagues are becoming, experts behind the computers. Either you're planning, you're contouring, or you're filling up forms, or you're entering notes. The patient, I think all of that should go, and we should
Yeah.
focus on patient care. We are a particularly vulnerable lot as far as that is concerned.
We are, and it's easy for us to sometimes get painted as
Yes.
providing a service,
Correct.
providing technical skills, right?
Correct.
And we have to remember the oncologist side,
Yes.
is the key focus. And if you don't care for patients, and I will add, if you can't follow them, if you
Yes.
don't get to
Yes.
see the late consequences of radiation therapy, when things go well, but also when things don't go as well, and or the patient has a recurrence, particularly in centers like Mumbai, where you're going to have individuals traveling, potentially from all parts of this huge subcontinent. And then they might go back, to their village or other town that they came from. I think just maintaining the communication with the local physicians, making sure that, particularly for our trainees and junior faculty, that they get to see patients and understand what it is to follow them over the long term. And it's not just my 5 treatments are done and I can move on, right? That culture, I agree. I think we have to be very careful to not lose the
Correct.
doctoring.
Yeah, yeah. So, since many years, we've ensured that all the patients that we treat are followed up with us, in addition to the urologist and medical oncologist if they need.
Awesome.
But every single patient, if they are on follow up, they see us as well. So we have probably a better feel of the side effects or the radiotherapy related issues or other issues that come up, and that's a big win. I mean, that's a big plus that we have. So and that
You-
helps with developing the data, that helps with developing your thought process, that these are the problems. And those are the ones that bring up the interesting questions.
It's so true, right? And it's incredibly important, like you said, because if you don't know what is going wrong or
Yeah.
what is going well, how will you design that next,
Yeah.
critical, pivotal question? So beautifully said.
Yeah. You,
Um,
you, you can't just depend on V30 being less than 5 cc and be happy about that.
Right, exactly. I know. We got to get away from just looking at the
Yes.
voxels and actually
Yeah.
looking at the patients in front of us. So beautifully said. So I guess in our final minutes, any final words of advice or anything you'd like to share with our community? Again, realizing we have folks from all over the world who are watching and at all different points in their career. But I think, first of all, I hope they have the opportunity to meet you in person. As intimidating as it might be to meet someone like Dr. Murthy because he is so
Oh,
famous in our field and has contributed so much. No, I mean it. I think I want to just reassure folks watching that if you see him, you absolutely want to say hello. He'll have a huge smile for you and is one of the most approachable people I've ever met. And I say that with the most genuine admiration. So, but with that
thank you
being
so much.
said, is there anything
Thank you.
you'll like to share to those who haven't met you?
Because people often ask, how do we start? Where do we start? And that's where you started this interview as well. So, and this is what the advice I give to my residents who are moving out of the hospital, developing their own practice, going to other centers is have a robust database. Know what you're doing. Every patient that you treat, not as a research tool, but as your own service, you should know what you're doing. And a lot of people are either unable to do that or don't know how to start. So I think that would be the first step rather than designing a trial. Know what you've done. Make sure you see the patient on follow up and document all that somewhere in a simple Excel sheet or an SPSS. And over 2 years, you'll really, these questions will start popping up on their own.
Absolutely. Well, there you have it. You heard it here. And, I can't let you go without also pointing out you are, in my mind, an unofficial ambassador to the entire
Oh,
subcontinent of India. So, I hope that some folks will even get to visit you at your center and see your team in action. I think that that would be an incredible experience as well.
absolutely, absolutely. We are getting requests from US and Europe for people coming and visiting, and more than happy to host people. I only do GU, so if you're interested in GU, please come over for a few weeks, or few days, few weeks, or a month. That's up to you, and we'll host you, and we'll have a good time. Please
And
come.
you will be well fed, I have no doubt.
And your visit is due as well, Neha.
That's right. That's right. You can tell where I'm going with this, right? Fishing for that invite. No, absolutely. So, well, once again, thank you for spending your evening with us. I know that with the time zone difference, it's particularly special that you made the time for us. So, thank you so much, and thanks everybody for tuning in and listening to this latest episode. And I do hope that you get the opportunity to meet Dr. Murthy in person as well someday. So, but for now, take in everything he said. He's a smart man. So thanks,
Thank you
everybody.
so much. Thank you so much. Have a
Take
great day. Bye bye.